Hi, welcome to Guts and Glory, the podcast which delves deep into the complex world of gastrointestinal and HPB disorders. Join me every month, wherein we unravel the mysteries of these complex issues in candid conversations with leading experts who share their experiences, tackle contentious topics, and provide cutting edge insights. I'm Sadiq Sikora, and this is Guts and Glory. Hi, good evening. Welcome to the podcast of Guts and Glory, decoding the mysteries of complex GI and HPB problems. My guest tonight is, of course, known to all, is Professor Adarsh Chaudhary, a very close friend of mine, but more than that, he is a trendsetter in GI and HPB surgery. A little bit about Adarsh. I know Adarsh since I think almost 2 decades or more. Adarsh is a product of PGI Chandigarh, the prestigious institution in the country. And then subsequently, he has taken up leading roles in hospitals like GB Pant Hospital, where he had headed the Department of GI surgery at GB Pant. He moved to Sir Gangaram Hospital, where again he was chairman of the Department of GI surgery. And finally, he settled down at Medanta Medicity in Gurgaon. Welcome, Adarsh, to this podcast. And I really thank you for uh, taking me on this offer and agreeing to be on this podcast. Thank you
Thank
very
you,
much.
sir. Thank you very much, Sadiq. Thank you
Yes.
anyway. It's a pleasure being with you. And I'm absolutely thrilled to talk about a subject which is very close to my heart. And me and you have shared many such sessions in the past.
So let me tell my audience that Adarsh is almost synonymous in this country, and I'm sure in the lot of HPB forums, synonymous with pancreas and pancreatic surgery. And he has spent decades in this to sort of fine tune the process of going through this complex surgery of the pancreas. And I've heard him several times, and he makes the talks very interesting, Adarsh, with using the paintings, using some films. But uh, I'm sure some of this will come in this talk also, and that's what who Adarsh is. Uh, Nevertheless, Adarsh, what I want to start with is that, pancreatic surgery is like a high end of any GI surgical uh, procedures that we do. And we all know that at one point of time, we used to say that don't touch the pancreas. It's a hermit of the abdomen. If you disrupt it or disturb it, it'll explode like a volcano. And we all were very afraid of the pancreas for a long time. But just tell me, you are a student of history and you know how pancreatic surgery has evolved from Cordwilla, Koch, and so on, and Whipple finally putting his name to this uh, Cadillac of procedures, what we call as the Whipple's procedure or pancreaticoduodenectomy. So, can you just share how you think the history and the evolution of pancreatic surgery tells us uh, how the process of developing a surgery is evident from the historical evolution of this?
Sadiq, most facets of history are known to us. And pancreatic surgery is a living example of the fact that progress is a series of small changes, is not one big change. From the time that Whipple described his series of three patients in Annals of Surgery in 1935. I think there were three authors in that paper where they described three patients whom they operated in two stages of pancreatic resection. One of these patients died within 30 hours. The second patient died for about 8 months, died after 8 months for cholangitis. And the next patient died after about 24 months with liver metastasis.
Right.
And then in 1940, he published his paper of the single stage Whipple's procedure. And from that time onwards, there have been so many changes in the Whipple's procedure, small steps. First, we used to routinely ligate the pancreatic duct. Then it was decided to drain into jejunum. Once that was solved, how much of stomach to be removed, the problem of marginal ulcerations. Then came how to drain the bile duct. And then the progress continued. And today we have reached a stage when we are talking of doing laparoscopic and robotic surgery. If you see the time, the priorities are obvious by the type of publications. Initially, it was said that our main aim was to decrease the mortality. Then came how to do the pancreatic anastomosis, then his long term outcome, then his adjuvant treatment, then how to make the patient operation patient friendly. So we have had a what
Yeah.
you call it as a transformational agenda in this moving in this direction.
So, yeah, I think we'll touch most of these things, what you said as a journey of pancreatic surgery. I am very interested to know about your evolution and the history of how you went about developing pancreatic surgery in your own way and where you have reached now. So can you share that with us, that how it all started? It's a challenging area, why you took it up, what drew you to it, and how you have taken those small steps or large steps to reach where you are.
I could have given you a political answer saying I had great interest, I was very inspired, but that won't be true. The fact of the matter is, after I finished my surgical residency, Whipples was not a commonly done operation. When I was in PGI, the operation used to be done, and the day Whipple's procedure was to be done, there used to be a commotion in our ward that today a Whipple's procedure is going to be done.
Right. Yeah.
When I came to GB Pant Hospital, a lot of factors put together made me do pancreatic surgery. One of the factors was we had a very vibrant gastroenterology department. They were doing a lot of endoscopies and ERCP procedures. ERCP had just come in. GB Pant had one of the best CT scans. So a lot of patients of jaundice used to come to GB Pant Hospital, and our gastroenterologists could do ERCPs. They could find the pancreatic masses. They were doing biopsies. And then I had started the department of GI surgery, and I was kind of, I won't say forced, I was given a large number of patients of pancreatic tumor to operate. So I was not formally trained for pancreatic surgery because, there were no videos those days, neither I had the resources to go. So I was given a lot of patients I had to operate, and I learned on the job. The only thing I deserve credit possibly is I learned from my mistakes. Sometimes some of us keep making the same mistake again and again, call it experience. That's not fair. I made my mistakes. We lost some patients, but we learned from them. I was very fortunate to have a group of residents who were very committed. And we realized that pancreaticoduodenectomy is essentially an operation of discipline. There are no shortcuts to it. And every patient teaches you something.
True.
So I was, and I still am a student of pancreatic surgery because the day you start feeling that you mastered this operation, nature beats you to it and you're again to the ground.
But still tell me, I mean, like, doing this kind of surgery, uh, you would have had to speak to people, you would have had to interact with people. So, who were your mentors, so as to say, who sort of guided you through this process? Since you say that you were not formally, or we all didn't have that much of volume and experience to be trained in this. I realize that because it is same with what I faced at that time. So, but still, I want to know who influenced, what kind of influences and mentors you had who
Okay.
helped.
My greatest mentor was the National Medical Library. I fortunately lived opposite the National Medical Library, and I must confess, I would have. There used to be the Journal of American College of Surgeons was earlier called as SGO, Surgery, Gynae, and
Yes,
Obstetrics, and
yes,
there used to be a column in that, Surgeon at Work.
yes. I
I
remember.
used to be voraciously reading journals, trying to see techniques of pancreatic surgery, and I can say with arrogance or humility, there would hardly be an article on techniques of pancreatic surgery which I didn't read. I was so obsessed with my mistakes, my failures, that I read voraciously from these journals. Second thing which greatly helped me was that there was in 1990 in Delhi an international conference of the International College of Digestive Surgery. And it was organized by Dr. Manohar Joshi. And I can say till that time, that's the only conference from which I learned. Most other conferences, I don't think I've learned much.
You
In
teach.
that, I don't know about that. I
You
won't.
teach.
No, no, I don't know about that. Anyway, so in that conference, I met Professor Abdul Rahim Musa from San Diego, Professor Hans Beger. I met surgeons from Italy. And I must confess, and I've learned from them, that these great surgeons had tremendous humility. I asked them many questions, and they had the patience to sit down with me, draw diagrams, and tell me how to do this pancreatic surgery, what mistakes they made, their impressions. So I think these things, I think I have learned a lot in my life by asking questions. Mistakes we make is we assume answers. I've been a skeptic. I ask a lot of questions, and my learning comes from asking questions. And I think that's where I learned because now it's possible to see YouTube videos. You have resources to travel. I used to work in a government hospital. You two were the same state. We could not travel. We didn't have resources. So we learned on the job. But I must say that the journals and the techniques described there helped me a great way.
So I think what comes out from this is that there's no substitute for reading. There's no substitute for sort of getting the knowledge and exploring all the resources to get knowledge. I think that's a
And
important
and and, and Sadiq will agree there is definitely a need of some degree of obsession for something.
passion.
There's
Passion.
some degree of, you can call it passion, you can call it obsession. I was obsessed with how to do a pancreatic anastomosis. Those days, it was not standardized. There were there was an article I read somewhere, I'm forgetting the author, and the author said you should inject a glue into the pancreatic duct, a glue called neoprene.
Yes.
I thought that may be a great thing. So I asked
The
Johnson and Johnson people to get
Scandinavian, uh,
Scandinavian. That's right. No,
Scandinavian.
Scandinavian stick bang mark used to staple the pancreatic stump. So all these things used to be there. I read an article. I still remember the picture still in my mind. There used to be one surgeon, Obertrop from Norway or something. He used to staple the entire pancreas, and then where you see the pancreatic duct, take off that staple, and then you do the anastomosis. So these sort of things I still remember, and eventually now I realized that
We'll come
it's
to that.
yeah.
We'll come to the
Okay.
anastomosis. It's an important part of it. Uh, so, what I realized over a period of time that you can do a surgery in any patient or any individual. The outcome is dependent on various factors. Yeah, I want to tell you that there was a patient who was brought to me on a wheelchair with a nasogastric tube by his son, who seemed to have read a lot about the disease and the process. And he told the patient unfortunately had pancreatic cancer with lymph node metastasis, para-aortic, and liver metastasis. And he said to me that I want you to do a whipple pancreaticoduodenectomy in him. So I tried to reason with him and say that, this is the situation, it is too advanced. He says, don't worry about that. You just do the pancreaticoduodenectomy and just remove that liver nodule. The rest will, I have a friend, will take care of it with chemotherapy. So I said, why don't you find a surgeon who wants to do it that way? He says, that's what I have found you. And can you please do it? So the long and short of this is that how do you choose a patient of for to offer them a pancreaticoduodenectomy? Because I feel it's a very critical aspect of selecting a patient so as to ensure that you provide good short-term and long-term outcomes.
This is a question to which I do not have a definite answer. And what you said is so right. In the movie Harry Potter, there's a quotation which says, which is absolutely true, that it's our choices which determine things, not our abilities. You may do the best operation in a sick patient, it's not going to work. To me, two factors determine. One is whether I can completely remove the tumor, to say what is called as an R0 resection. And second is this patient fit enough to tolerate surgery or not? To say to have rules of thumb to decide the second part, fitness, it is something you learn with time by making mistakes. When I was in PGI, my professor used to come to the ward and he used to take a round and look at a particular patient and he used to say, this patient doesn't look well, just get his X-ray abdomen. Those days we had no ultrasound. You get his X-ray abdomen. And I used to think, what sort of a man is he? He's just looked at him and he's asked for an X-ray abdomen. And majority of time he was right. There is a dimension to thinking which you can't put into words. A patient who comes on a wheelchair, who's coughing, who's sarcopenic, who's so frail, your operation may be a success, but the patient will not survive. We made these mistakes. When you start your results getting better, you start pushing the boundaries of
Yes,
your surgery. Now,
yes,
where to stop is an important issue. I still remember Dr. Musa. I was sitting with him and talking about what to do. He used to smoke a cigar and he was smoking his cigar. Then he looks up to the sky and he said something, son, you can't beat physiology. At that time, it didn't make much sense to me. But today, I think that's a truth. So learning to realize your limitations, somebody who's frail, who has more than two organ system failures, somebody who's not able to get off the wheelchair, who's been smoking regularly, possibly we will not operate these patients. I'm not saying we outrightly reject them. We say,
absolutely.
go home, do some prehabilitation, come back. And there are some patients who come back and they've done well. What I'm saying is you possibly have to pause a little bit and not take everybody straight to the operation theater.
So you have written, or your group has written a lot about sarcopenia, assessment of sarcopenia, prehabilitation. So just sort of elaborate on this to me, that what is the process a patient goes through when you see him in the OPD?
We don't use sarcopenia to reject a patient, but it tells us we use sarcopenia currently in a patient who's receiving chemotherapy before surgery. You have a CT scan, then you use chemotherapy, and then you do again a CT scan. If these patients have significant amount of loss of psoas muscle, we are a little reluctant to operate these patients because we have realized that these patients don't do well. So literature suggests that preoperative chemotherapy does not affect outcomes, does not affect the complications. But our experience suggests that maybe that is right. But once these patients develop a complication, their outcome is not so good.
Yes.
So we use, and I also believe in years to come, sarcopenia will become one of the factors to determine the extent of the disease a patient has. Like I've been many times asked a question that suppose a patient's serum albumin is 1.2, will you operate this patient or not? So the
Yes.
answer I give is that this is possible, but in my experience, a vast majority of them will have a disseminated disease. If you do a PET scan or you do a laparoscopy, you will find small peritoneal metastasis or liver metastasis. So serum albumin is a surrogate marker of an extensive disease process, not only a marker of malnutrition.
So, you know, uh, I realize that of the ABC for evaluation of these patients, we are quite focused on the anatomy and the biology of the disease, but we just, I think, are a little superficial in looking at the condition of the patient. And as you have highlighted, I think we need to pay a lot more attention to this aspect so as to ensure that you select the right patient for the procedure.
The problem with most of us as surgeons is that over years we have developed stereotyped goals. Our goals in whipple still last few years was till a patient gets discharged if the patient is doing well. That used to be our endpoint. Am I right? But if you take the arithmetic of consequences, one of the problems of operative mortality is we take 30-day mortality. We should take a little extended mortality.
True.
So I need to see that we need to see what do we do to these patients. So I have realized that sometimes you operate on a sick patient, though he gets discharged, there is inability to thrive. They cannot eat, they cannot do well. So you need to choose your patients carefully, because doing a half-hearted procedure, not doing a extensive resection, not doing an R0 resection doesn't help the patient. I better wait for a time, do prehabilitation. So because prehabilitation works, and it's a very good way to exclude patients also,
Yes.
because cancer cachexia in the early stage can be reversed once it's beyond a certain stage. No matter what you do, these patients are not going to do well. It's like a biological determinism as to which patient should be operated. You must match a trick to the terrain. Like, I know you might ask me again, I won't do an extensive lymphadenectomy in an 80-year-old man, but I'll do it in a 40 years old patient, because no matter how active you feel, age is age.
Absolutely. So let's move on. We talked about selection, and over the years, the technique of doing a pancreaticoduodenectomy has evolved tremendously. I mean, I remember being at Johns Hopkins and seeing John Cameron and his team operate, a kind of father of pancreatic surgery with 1,000 whipples without mortality and things like that, as you said, early outcomes. But the way the uncinate process was taken out, we don't do it anymore like that. So there is a lot of evolution of techniques. What, according to you, are a couple of techniques which have made an impact on how A, we achieve R0 resection, and B, we minimize the morbidity and mortality, and three, how it improves the overall outcome in the long term also.
Sadiq, one of the greatest contribution to pancreatic surgery, you'll agree, has been radiology. The present day CT scans give such a nice vascular anatomy. They tell us. So there are very few surprises on the operation table. So we
Absolutely.
are forewarned. We know beforehand that in this patient, there's a replaced right hepatic artery. In this patient, I might need to do a venous resection. And like I also see a lot, I'm very particular to see what is the texture of pancreas, because you can have a rough idea. And if there is associated pancreatitis or not, then I will not operate this patient. If the pancreas, you see the boundary shows some patient has got a stenting done, I'll say better wait 2 weeks. So preoperative radiology, clinical staging has gone a big way. Second thing, what we have realized is that how is surgeon an important prognostic factor in this procedure? Where do we fail? Most surgeons do the surgery well. Two places we fail. One is that we are not, most of the beginning when you're surgery, you are not removing the uncinate process properly. The retroperitoneal margin clearance is very important because that is technically demanding. We have not seen our seniors do it because they did not know that that time long-term recurrence was not a question. Now we realized most local recurrences occur dorsal to the superior mesenteric vein and portal vein. Am I right?
Yes.
So I
Yeah.
spend about 45 minutes to 1 hour in that area to do an adequate amount of clearance because majority of resections we do is LV2 type these days, occasionally LV3 type. So we spend a lot of time there. So we have realized that this is one way we can make an attempt to decrease the retroperitoneal margin positive.
And are
Small things like, yeah, small things like not losing blood. There has been a great improvement in the technique of pancreaticoduodenectomy or gastrostomy, whatever you are doing. In high volume centers, we have nearly mastered that technique. And then third important thing is the surgery being done in high volume centers. High volume centers, you'll agree, contribute not only because of increased resectability, better resection, but to my mind, the complication rate is the same possibly as in another unit, but course correction is faster, quicker, and better. So you spend less money, less time, and long-term outcome also is possibly better in high volume centers.
so I think the three components which I feel need to be addressed and see the impact of that in the outcome. One is vascular resection, which is venous and arterial. We take it separately. And the next one is lymphadenectomy. I'll take lymphadenectomy first. So lymphadenectomy, there are several randomized trials which had come in the early 2000s and 2010, which all from Italy, USA, and things like that. And they all said that extended lymphadenectomy did not
We all
aid
agree that
the survival.
improve. That's
And
right.
it was, and in many other diseases, we have realized that it is more a marker of prognostication and
That's
disease
right.
uh, or upstaging or downstaging the
It stages the disease better.
stages the disease. So, what is your view on lymphadenectomy, and is extended lymphadenectomy impacting the survival?
Sadiq, I am also like you, a student. I don't have any personal study, but we also do a limited lymphadenectomy. We do not do an extensive lymphadenectomy, but even the definition of what is standard lymphadenectomy is controversial. So we will routinely remove station 5, 6, 8, 12, 13, 14, and 17. That's what we routinely do. You can ask me the question, suppose, or maybe I'll ask you a question. Suppose if you have a patient who has large para-aortic nodes and you do a frozen, will you do a whipple in this patient? The tumor is resectable. Before you give the answer, I will give my answer. We will resect these patients with the knowledge that survival in these patients is not going to be as good as those patients in whom nodes are negative. But we do not have a definite answer in literature. So, what is standard, what is extensive, it's still very nebulous. But we do not do an extended lymphadenectomy. We do a standard lymphadenectomy.
Fair enough. What about venous resection and arterial?
Uh, okay. You will agree with me that venous resection is more often a reflection of the topography of the tumor. Like most uncinate process tumors will need a venous resection. So we are not very, I mean, we do venous resections. If it's an end-to-end anastomosis, we do it ourselves. But if you have to put a graft, at least in my hospital, we call a vascular surgeon because they can do it better, faster, and quicker. Because what happens is that if you take too much of time in doing this anastomosis, the bowel gets congested. We don't want that to happen. Though literature has not mentioned this aspect, but at least in our experience, we realized whenever you do a venous anastomosis which lasts long, the bowel gets congested, and that may be one of the reasons where pancreatic leak occurs. So venous resection is okay. We have not done a superior mesenteric artery resection, and literature also suggests. But in last 2 or 3 years, a couple of patients who had borderline resectable pancreatic cancers who received chemotherapy, we operated we did a small resection of the hepatic artery and called our plastic surgeons to do a microvascular anastomosis. But if you do I mean, there's a belief that if you do an arterial resection, it's safer to do a total pancreatectomy because if you have a leak, then the consequences are disastrous. But our numbers are very small for me to say make a statement with some degree of confidence on that.
So you agree that most, I mean, I recently went through a meta-analysis of arterial resection, and although there is growing number of people
Yeah,
doing and volume of it, but
that's right.
it still has not shown there's an increased complication rate, there is a higher uh, mortality, and
That's
the
right.
outcome is not really
Not
uh,
really beneficial. Yeah, yeah.
improved
But the
despite.
trend, but the trend is coming towards we are doing procedures like divestment and things like that. We are pushing the boundaries, but before we can say that it really alters outcome, it will take more time.
Great, great. So let's come to the Achilles heel of pancreaticoduodenectomy, which is the pancreatic anastomosis. So first, I'm very keen to hear from you that how has your technique and strategy of pancreaticoenteric anastomosis has evolved over these years, and what do you do now?
Like I said, I was not formally very trained. I initially dabbled with various things, and there was a time I was going around saying pancreaticogastrostomy is a good operation till I had two or three leaks, and then the consequences of a leak of pancreaticogastrostomy is disastrous.
Yes.
So coming to the point, my favorite procedure is to do a duct to mucosa pancreaticoduodenectomy. We keep it very simple, and I always use a loop for my surgery, and in about 90% times we can do a duct to mucosa. And if for some reason the duct is not dilated, we'll do a single layer interrupted furrow PDS anastomosis between jejunum and the cut head of pancreas. But my belief is that no matter what anastomosis you do, the single most important thing is to mobilize the pancreatic stump well. If the pancreatic stump is mobilized well, it should be it should fall into the jejunum because that's the way it is. Because pancreas is a fixed structure, jejunum is a mobile structure. Our technique is that the jejunum goes under the pancreas, so pancreas is on top. It's like a funnel draining down. So if you mobilize the pancreas well, handle the pancreatic stump well, not lose too much of blood, and take your time to do a pancreatic anastomosis. That's the trick to it. But to say that one suture here, one suture there, I think that discussion is futile. Whatever has given good results in your hands, that's what matters.
So till a couple of years back, in most of the journals, we would see reviews, meta
Yeah,
of what is the perfect reconstruction,
that's right. That's right.
e.g., gastrostomy versus jejunostomy, and the types of pancreaticojejunostomy, so on and so forth. So, if I say that that debate now should be put to rest, and we
Thankfully,
need to look at
other
what
things.
kind of anastomosis,
Yeah, yeah.
is that
I think
correct?
it's we all have understood that whatever gives good results in our hands is good enough. Like various ways to reach God, whichever way you do, it's your way. So that I think discussion should stop.
Just meticulous
Anastomosis.
anastomosis of whichever way you
Way
prefer,
to do.
but do it nicely.
Nice name.
Ensure that there is
Because when you are young, you believe gimmicks work. Because when I was young, I used to believe if I do a bad anastomosis, a stent will protect. But surgeons should realize that God hates surgeons. You make a mistake, you pay for it. So I've seen my own anastomosis when I had to reoperate these patients who leaked. The pancreas is on one side, the jejunum is on one side, the stent is lying in between. The stent does nothing. You do a bad anastomosis, stent or no stent is going to leak.
right, right. So, uh, anastomosis and all is fine. Now the key comes is what about the other aspects? That is nutrition, drains, uh, and ERAS protocol. So take me through this. That do you people routinely do a feeding port or feeding jejunostomy? or
Uh,
any other form of
we do
nutritional
not.
support.
Sadiq, I think a year back we published a paper discussing about who needs nutritional support after Whipple's procedure. We do not believe in doing a routine feeding jejunostomy. We will only do a jejunostomy in two groups of patients. One is the ones who primarily present with gastric outlet obstruction, like duodenal tumors who had gastric outlet obstruction, stomach is usually distended. We
Yeah,
believe these patients are going to have a delayed gastric emptying for a long time. And jejunostomy is a good way because parenteral nutrition, economically, and other issues is not as good. Second, we identified patients who are on antidepressants or any other antipsychiatric medicines because we realize these patients have long durations of ileus. So, in our experience, then their intestines move slower because of the antidepressants they take. In them, we'll do a feeding jejunostomy. Otherwise, we will not do a feeding jejunostomy in majority of our patients because, contrary to popular belief, it's not as that innocuous procedure. It has its own complications. Regarding drains, like I said, there are three kinds of pancreatic surgeons. One who routinely drain, second, a subgroup who don't drain, and thirds are selective drainers. We are selective drainers. If somebody's surgery has gone well, is young, no multivisceral resection, everything is good, we might not put a drain.
low fistula risk.
Rate and risk and everything. So that's about 30% of our patients. The interesting part is whenever I'm operating and I'm there till the end, I will not put a drain in majority. But if I'm not there, my colleague is there. He nearly always says, I think we better put a drain. But by my people say that what's the harm in putting a drain? My argument is that drains are very sensible. The drains have a brain of their own. Whenever they are meant to drain, they don't work. So you would have, so I will and so we put a drain, but whenever there's you've seen yourself, whenever it's a doctor's father or a important politician, the drain stops working. You have to do other things. So I don't have great faith in drains. We've had patients who had 1.5 liter, 2 liter of blood in the abdomen, and the drain has not drained because it got blocked by a clot. So we put drains. So that's what we do. We are great believers in ERAS, and I think it works. It's very useful. It does two things. One is it takes away the confusion in patient care. The whole department knows what has got to be done. This is a streamlined approach. The nurse knows that the antibiotics have to be stopped on second day, Ralstum has to come on first day, patient has to be mobilized. So there is uniformity of care. To my mind, that's a great time saver, money saver, leads to early discharge, early mobilization helps. Second thing, it's very important for us, we realized is that it's a very good surrogate marker of a complication developing. If a patient does not follow the trajectory of recovery we are expecting, then something is amiss. If one of our patients cannot take oral feeding till day 3 or 4, we start getting worried. So, deviation from critical care pathway means something is amiss and it heightens your threshold to start looking for it.
Uh, let's come to borderline resectable pancreatic cancer. Now, this term has come a decade or so back. And my question to you is, A, are the definition credible, uniform, to be used universally in all patients and by everyone? And two, how the definition of this entity has changed the management of pancreatic cancer?
First of all, Sadiq, I think it makes sense to classify patients into these group of definitions because there's unfair to reject these patients. These patients need chemotherapy, oblique radiotherapy before surgery, and many of them can be taken up for surgery, and many of them have achieved an R0 resection. But there is a term in cognitive science called as narrative fallacy. What it means is when you give labels to something, you believe you understand them. Definitions belong to the definers, not the defined. So you show the same scan to two different radiologists, and one will label it as borderline resectable, and the second will label it as locally advanced. So the margin is indistinct. It is like the colors of a rainbow. You know they are different colors, But where they merge into each other is not clear. There is definitely a subgroup of patients, yes, who do not have metastatic disease but have extensive involvement of the spermacentric vein, abutment of the artery. These patients deserve chemotherapy, a relook, and resect. But to
Of
say, but to say that we know it absolutely, I think that's not true. There's a subgroup of patients, but it makes sense to define them in some labels, but to realize that these labels are not accurate.
right. But you think putting this category has brought in a certain other paradigm for treatment of these patients?
Definitely, definitely. And I think to have an always a nihilistic approach towards pancreatic cancer is bad. Definitely, there are these patients, you give them chemotherapy. I have also patients in my experience in whom we given them chemotherapy, we operated them, and their survival is as good as bad as patients who were operated without any chemotherapy or radiotherapy. So we should definitely have an aggressive approach to these patients because what choice do we have? Because and these patients very nicely biologically select themselves because when you give them chemotherapy, you can come to because radiologically they don't change their performance status in CA19-9, you see, they've had patients in whom during chemotherapy they develop metastasis. So they've
Yes,
automatically selected themselves. But I
yes.
definitely believe that they should not be discarded. Patients with good performance status, we must give them an opportunity with chemotherapy. And I foresee in future with better chemotherapy being used, we're going to have more and more of these patients being taken up for surgery.
So we know that in pancreatic cancer, adjuvant chemotherapy in the post-operative period is almost a standard of care, right? With the borderline resectable, what we've understood now is that the new adjuvant or upfront chemotherapy, with or without radiation, has sort of brought to fore the fact that some of these patients who respond well could be taken up for R0 resection, right? What about doing upfront chemo for resectable pancreatic cancer? What are your views on that?
In all of us who are doing pancreatic surgery routinely, there is a collective awareness of the fact that surgery alone is not a good thing. We cannot improve survival. We have to add something to it. The problem with adjuvant chemotherapy is that whipple, pancreaticoduodenectomy is a major surgery, and many patients have complications, surgical site infections. Their chemotherapy gets delayed.
Yes,
So, preoperative chemotherapy is a very attractive option because you can finish all your chemotherapy before surgery. It can sterilize the boundaries, can increase greater chance of R0 resection, a biological determinism, theoretically very attractive. But like many political statements, though theoretically attractive, it has not matured into patient benefits. It might happen in future. There's a lot of study, a lot of belief, like people like Doug Evans and many other surgeons believe that exposure to chemotherapy for long plus radiation improves survival. They're convinced of that. But for that to become the standard of care, we need some more time, more data. But the whole idea is very attractive preoperatively to give chemotherapy.
so as you say, it's not a standard of care as of now. And I went through a couple of very recent systematic review and meta-analysis of randomized trials for preoperative in resectable, preoperative chemo in resectable. And this particular paper did a statistical analysis, which I didn't understand. But at the end of that, it said that there was no benefit of doing neoadjuvant therapy in resectable pancreatic cancer. But I feel, the concept of neoadjuvant therapy, as in esophageal, rectal, is it has to come in pancreatic cancer because I think we have reached the limit of what we can do surgically, and we need other modalities in the right order and the right components, which I think both are missing at this point of time. What do you think?
I'm very right. I think all these studies in other cancers, there is definitely, these studies have implanted an awareness into a surgeon's mind that surgery alone is not good enough for aggressive diseases. We need to work in teams, especially a disease like pancreatic cancer, which is known as a silent killer. You can never diagnose it early. It is biologically so aggressive. Pancreatic cancer is surrounded by a fibrotic stroma, which itself is a mystery. Whether it's a friend or it's a foe, we don't know. My current interest is in studying what does it do. We have so many unanswered questions. One thing is sure, that recurrences, when they occur, even in patients in whom I've done an R0 resection, is an implicit reminder to all of us that there is much more happening than we know.
Absolutely. Absolutely. Now, Adarsh, I come to the point which a lot of times when pancreatic surgery or even any form of HPB surgery is talked about, there is a concept or thought which comes in is about centralization of care. So, what do you think about this centralization of care?
I think there are two things. One is what is practical and what is ideal. Ideally, considering totality of facts, there is no doubt that centers which routinely do any operation by whipples, be it esophagectomy, be it surgery for morbid opacity, their results will be better because they choose their patients well, they match the procedure to the patient, the complication rates are lesser, they think in teams, complications are detected earlier, managed earlier, long term outcomes are better. Whether this is feasible or not is something we need to discuss. Definitely, there are some patients who cannot travel. Absolutely. But there's a large majority of patients who are not even told that there are high volume centers. If you want to go there, your outcome may be better. So we have problem on both sides. Some patients cannot travel, and some patients are not even offered. They are told that we are as good as anybody else. So we need to understand the difference. Yes, to say that everybody can travel is not right, but definitely pancreaticoduodenectomy is not to be done by fly-by-night surgeons. If it should be done by a surgeon who may not be working at that moment in a high volume center, but has been trained in a high volume center. He has experienced, he has seen, he's understood the nuances of that because he will be smart enough to know this is the patient I can manage, this is the patient I should refer. So we need to make sure that our knowledge of pancreatic surgery is centrifugal. It goes to everybody to tell them this is what you can do and this is preferable not to do. So that's my belief in that.
Yeah, I totally concur with that. I think as you've been mentioning, management of these patients need teams and even multidisciplinary
Oh
teams,
yes, oh
both in
yes,
terms of management and decision making to begin with. So you
absolutely.
need to have this whole thing in a place. And if you have that and people are trained in good places, then I think they could embark on that and take up those things. Uh,
You yourself know, Sadiq, one of the most important member of any pancreatic surgery team is a radiologist.
Absolutely.
We need to put percutaneous drains, occasionally embolize, preoperative staging, sit down with them, discuss the scan.
So I come to this contentious but uh, interesting situation. We've, I include myself in this with you, that we have trained ourselves to do a good pancreatic surgery. And then comes the laparoscopic whipple procedure. And then after some time comes the robotic whipple procedure. And that means now you have to go through another learning curve and another learning curve. And the patients who come with you with so much of belief and trust would know that you have to go through another learning curve. So, what is what should people do? Uh,
Uh,
A, is laparoscopic pancreaticoduodenectomy here to be done? And then the next part is robotic. And should everyone embark on it?
Thankfully, I am not overdosed with the illusion that I can do everything. I don't suffer from that illusion. I know my limitations, but yes, I do an open pancreaticoduodenectomy, but that doesn't mean the patient should not be offered. There are people in my department, younger people, who do laparoscopic also and who do robotic also. It is so unfair for some of us to have a cerebral rigidity quotient of 100% to say it is only done this way. That is not true. We have to do a safe, effective, good clearance pancreaticoduodenectomy, be it laparoscopic, be it robotic. But looking at laparoscopic and robotic, I think the future belongs to robotic because you have the ability to suture much better. So I essentially believe learning robotic is easier than learning laparoscopic. But if you can do a oncologically as good an operation, it doesn't matter how you do it, so long as your clearance, your complications rates are acceptable.
So, do you think we have reached a stage where we can say that this is the best way to do whipples or pancreaticoduodenectomy? Open, laparoscopic, or robotic?
It all depends on who is doing it. It's the surgeon who decides who's doing it. There are bad open surgeons and there are excellent robotic surgeons. So it's the individual. You have to be honest with yourself as to what degree of clearance you are offering. There are players who play T20, there are players who play one day cricket, there are 5 day players, and today we have separate teams for that.
So I think it is interesting that you said that it depends on the surgeon and the team, because what happens is that when the new procedure or a technique of doing a procedure comes about, everyone wants to be on the newest bandwagon. And therein, the initial part of learning, getting trained, and then doing part gets lost when people start doing the first one themselves without adequate training.
Oh, what you said makes a lot of sense to me. Whenever I go to a conference, a surgeon will always walk up to me, and the first thing he says, "Sir, I've done 2 laparoscopic whipples." So, out of interest, I said, "Why did you do laparoscopy?" Out of curiosity, and 99% times they will say, "Because everybody else is doing it." That's a very poor answer to my mind. If you say that I'm interested in decreasing the hospital stay, early discharge, more patient friendly, that would make sense. Just because you don't jump the bandwagon, to my mind, is not a very good answer for that.
So I think the key thing is that the current generation who's coming through uh, various training programs where they do this laparoscopic or robotic, and if they get trained into that, then that's the right way to proceed. Get trained and then gradually choose your patients well and then
Absolutely.
do the procedures.
Absolutely. Agree with you. But here again comes the fact that we discussed beginning, choosing the right patient for the right procedure. The
Yes.
worst thing happens when you want to fit a patient to a procedure.
But uh, seriously, now you are a master of pancreatic surgery. You say that you are still a student of pancreatic surgery, but I want to ask you that people who are listening to this, uh, who are residents, who are interested in pancreatic surgery or want to take up this, what you would tell them, what gems or piece of advice that you would give so as they can embark on the career of being a pancreatic surgeon and be successful as you have been.
The first thing is to realize that broadly in a stage of learning, there are 3 points. You're an amateur, you are a teacher, and you're a master. The line from an amateur to a teacher is okay, but from a teacher to a master is very long. I'm no master. I'm not saying it in humility. That's a different thing. Surgery is a process. Unfortunately, many of us believe that there are any quick ways to it. There's no escalator. There's only a staircase to it. You have to climb it. And pancreatic surgery is not a surgery which is very rewarding in long terms because recurrences occur. Most of our patients don't live long. We work very hard. So if you are committed to this, if you have care, commitment, and compassion for patients with pancreatic diseases, you should pursue pancreatic surgery as a career. And this is one subject in which there is as much as a cerebral dimension as there is technical dexterity. Only with technical skills you cannot get good results in pancreatic surgery. There is a lot to be done preoperatively, lot to be done postoperatively, and of course, the fate of the patient is decided on the operation table. If your attention span, unfortunately, in surgeons, we don't study attention spans. Some of us have an attention span of 1 hour, 4 hours, 8 hours. If you have a short attention span, pancreatic surgery is not for you. There's nothing wrong about it. You can do other procedures. All
Yeah.
fields are glamorous. You need a long attention span. You need to have a great skill set. You should know nuances of vascular surgery. You should know laparoscopic surgery. You should know robotic surgery. You should know physiology. You should know nutrition. You should know pancreatic physiology before you can become a pancreatic surgeon. Like they say, nothing difficult is ever easy. So if you want to get into this field, life is tough.
Life is tough. Thank you so much, Adarsh, to be agreeing to be on this podcast and sharing your insights. And we all know that you're an excellent orator and you have this remarkable ability to get the point across in your baritone voice, which is the additional bonus for anyone who hears this. So it has been a great joy to be talking to you. And I'm sure all the listeners would enjoy listening to these pearls of wisdom from you on pancreatic surgery. Thank you so very much once
Thank
again.
you so much, Sadiq, for inviting me, and I absolutely enjoyed talking. Thank you so much.